Okay, I'm going to make a start. So, very welcome, everyone. If you're here to talk about preventing mental health crisis through better collaboration, then you are in the right place. Before we start, I'd like to make some introductions. I'll start with myself. I'm Andrew Laird. I'm the Chief Executive of Mutual Ventures. We're a public service consultancy that works with central government, with councils, and with the NHS to make public services better, more sustainable, and more connected to communities. And I'm really delighted to be joined by some excellent panelists today. So Sarah Burman is the Assistant Director at the Kenton Medway Adolescent Hospital and the Crisis Care Pathway. Ellie Watson is the Pathway Lead for the Health-Based Place of Safety at Kenton Medway. Steve Kay is the Assistant Director at Rochdale Council for Early Help in Schools. And my colleague Isak Maya is one of the consultants here at Mutual Ventures, but until quite recently spent 7 years at the Met Police. And Isak will be kicking us off with some reflections on his time at the Met and what it meant and what the experience was like responding to mental health crisis. Before I start, just a little bit of background. This conversation is really current, and it comes against the backdrop of the Met Commissioner, Sir Mark Rowley, announcing that they would be stopping attending mental health call-outs. And that obviously will put a lot of pressure on other services. So the question arises, how do we move from a discussion around whose responsibility it is to respond to mental health crisis and thinking more about prevention and the way that services can collaborate to try and increase prevention. Before we start, just some housekeeping. We are recording, so there's no need to make copious notes. If you want to, we will be sending out the recording link to this, and you can rewatch it or you can share with colleagues. Also, if you want to ask questions, and I do encourage you to do that, please use the Q&A function at the bottom. Unfortunately, because there are quite a few people on, we're not able to let people speak and ask their questions themselves. But if you pop your question into the Q&A function, then I can put those to our panelists later on. So hopefully that's all clear. So to kick off, Isak, I'm going to hand over to you.
Thanks, Andrew. Hi, everyone. And as Andrew mentioned, I was in the Metropolitan Police for 7 years in different roles with different purposes. However, the one thing that remained a constant was my engagement with vulnerable people, and unfortunately, in some of those instances, people suffering from mental health crises. And what that would look like day to day, just to give an example, would be executing Section 135 warrants under the Mental Health Act with the NHS, local authorities, where a mental health nurse may apply for a warrant to the court so that a person can be assessed in their home or even escorted to a health-based place of safety and assessed and potentially sectioned. My article kind of spoke about the other angle, so Section 136, where I was detaining and sectioning people who either presented a harm to themselves or members of the public. And just to give a bit of context for those who've not had a chance to read my article, it goes on to describe a very typical Friday night in London where there's a lot going on in terms of robberies, pub fights, domestic incidents, and everything else you can think of. And I get diverted away to deal with a vulnerable person who's experiencing mental health problems. And that incident itself lasts the best part of 12 to 13 hours from start to finish. Resource point of view, there are questions there, but more importantly, I felt in these incidents, there was a lack of a collaborative process from a multi-agency angle anyway. So what do we do on a Friday night when you can't get hold of the next of kin of that person or their social worker or their mental health nurse? What is the plan B where there isn't a direct process in place always, and what it felt like? And I don't think my situation is unique, and if you speak to other frontline personnel, they'll probably have similar stories. Where is this collaboration, and why is it that it feels like there's a gap sometimes? So yeah, my article went on to describe that and that night in question, but I'm quite keen to hear the panelists' views and thoughts around early help and young people and mental health in that context. And if some of that learning can be applied in a wider frame to adults more generally, especially when people hit the age of 18, to ensure that that support network and that framework is still there so they don't experience mental health crises. And I'm also excited to hear about the panelist's views on Right Care, Right Person, the new initiative that looks like it's going to be rolled out across the UK. I know Steve's done some great work with a police force already in implementation of Right Care, Right Person. So yeah, I'll hand back to Andrew, who will continue the discussion.
Thank you, Isak, for that introduction. So I'm going to go straight to our panelists here without further delay. So Steve, Isak mentioned some work you're doing, but it'd be great to get your initial reflections and some of your own thoughts on this topic. So you just, you're on mute, Steve.
Sorry.
Bingo, mute bingo.
I'm back. So first of all, what I would say is in terms of the initiative by the Met Police, I think the core principles are correct. They're absolutely right. But the implementation of it is where it becomes sensitive, where it's not simply a case of saying, we're not going to do that anymore. It's got to be planned in a coordinated way, because the Met Police are a really, really important part of the system, but they're not an island. And so what they'll need to do is ensure that their relationships and their collaboration is really, really key across all of the London boroughs, but then also with the health infrastructure within that, with across the Met, and also communities themselves, voluntary and community sector, which is going to be really, really important for them, because otherwise what happens is you end up playing whack-a-mole. So something will happen here and so I don't know, Met Police or a health system or a local authority will reduce demand in one particular area, and then that just causes an issue for someone else within the system. So it's got to be managed strategically. It's got to be coordinated. It's got to be collaborative, because service-centric or organisationally focused solutions working in isolation just don't work. It's got to be about that collaboration. And also what I would say is my view would be that it's got to be strategically managed, but also hyper-local, so down to ward areas, and that understanding of demand across the system, across all of the key partners, is really, really crucial. Because if any partner just pulls out, it's a little bit like playing community kaplunk, because you end up kind of pulling little bits out of the system. We're not going to do that, and that's not our job, and then the whole thing will just implode. So it's a brilliant concept. I've seen it work in Humberside, which Lee Freeman, the Chief Constable, was managing. It's not without challenge, and there's always that kind of constant dialogue that needs to take place. But ultimately, at its core, when it works effectively, is where it's outcome focused. I can say a lot more about that if you want at this point. So if you're looking at reducing crime rates in a particular area, one immediate thought would be, well, we need more police. But then, and of course, more police is always a good thing. But that's not going to tackle the issue, because actually when you look at the core drivers of need in a particular area, you think about the thing that comes through any local authority's safeguarding front door. You think about parental mental health, you think about drug and substance misuse, you think about domestic abuse. Very often there's a core mental health element within that, but also that all of those things are systemic issues that need different services to respond at different times. And so there needs to be that strategic agreement and that coordinated approach at a place level, but then also it needs to be at that hyper-local level, in particular ward areas, where there are those issues. And the thing that is actually going to reduce crime rates would be, actually, it might be, depending on what the demand analysis is, an increase in voluntary and community sector funding for particular areas, or it might be that a particular health provider needs additional resource, or it might mean that there's a collaboration at a family hub level with health visitors, early intervention policing teams. It might mean that schools are involved. If you asked young people in Rochdale what their top priorities are, one of the priorities is mental health, right across the piece for young people. I'll talk a little bit more about the BWell survey that happens across Greater Manchester, which has been introduced across the southeast now later on. But there's a real energy behind it, and I think we need to see it as a whole system issue. What can't happen, and what would kill a brilliant idea, is if it's not done in collaboration and really carefully planned.
Thank you, Steve. Just a couple of quick questions there. You talked about the importance of coordination between the different players who have to work here, and you talked about having strategic alignment around governance, a shared vision at a place level, but also at the ward level, that hyper-local, sometimes based around a family hub maybe. Can you just talk a little bit more practically about how you get both of those levels in place? So the strategic agreement between the leadership of the different organizations, but then also that hyper-local actual delivery on the ground.
Yeah, absolutely. So like everywhere, it's got a new health infrastructure with the ICS or local care organisation, for example. I'll give you an example that relates to special educational needs and disabilities. So if young people, unfortunately, with SEND, are sometimes disproportionately represented where there are issues of criminal exploitation, for example. And so what we've done in Rochdale and across Greater Manchester, we've got a strategic agreement, a mandate with our health providers around special educational needs, and also an emerging one in terms of serious violence, which is not just about SEND, but more broadly, every local authority area is in this space. So we've got that strategic alignment where we have a SEND alliance. We link to the local care organisation board. It's not it's like something that you would see in many other areas. But what we've also got is a commitment to the development of neighbourhoods. So Rochdale, as part of Greater Manchester, we have essentially 5 townships. So within each of those areas, we're looking at an integrated neighbourhood response and that means the local authority, health providers, the police, voluntary and community sector, where we're coming together to say, what are we doing in terms of our buildings? What are we doing in terms of our resource? What do we understand about demand? What does that mean for, say, at Middleton, North Manchester? What does it mean in terms of these particular ward areas, which are hotspots for I don't know, it could be domestic abuse, or it could be, actually, we've got some organised crime groups operating in these areas, or we've got an issue with SEND in this particular pocket of areas, or actually there's an increase in social care activity in terms of what the stuff that's going through the front door. So actually the response across those 5 areas is not the same, in the sense of it's not a case of having 5 areas and not like we need 5 things in order to be able to respond, because it's about the understanding of demand and the understanding of the data, and really, really importantly, the understanding of lived experience of those children, young people, families within those neighbourhood areas. And then a more bespoke response at a hyper-local level, at a family hub level, resources can be deployed appropriately and more effectively than they previously were. If those organisations are not working together in close collaboration, then that's a waste of public money. Because actually you end up fighting 152 different challenges when actually there could be just one. And it sounds lovely and it sounds easy, but it's not. It's complicated, it's hard, but it's moving towards an outcome focused alliances rather than service-centric or organisationally focused solutions. And I think the key thing is getting everybody around the table, and it's hard. It's easier to say and harder to do, but really appreciating the involvement of schools, for example, which is massive. You're talking about hundreds of millions of pounds worth of public money happening within a local area, where often schools are seen as peripheral, and they're actually central often to some of these issues. And also a huge advocate of voluntary and community sector activity as part of the solution, and a valued partner rather than an also ran.
Yeah. Thanks, Steve. That's really interesting. So we've had, from ESAC's perspective, a police view, and then Steve from the council side. But it'd be great to get some views from the NHS side. So we've obviously got Sarah and Ellie. So Sarah, if I come to you first, and then it'd be great to get Ellie's thoughts as well.
Thanks, Andrew. I think Ellie and I will probably talk together, if that's okay. I think from our perspective, and Ellie, jump in if I'm going off track here, but I guess the document, I think it's a really interesting document in the sense of identifying as a system where the needs for those with a mental health difficulty are placed. I think for us, as a inpatient adolescent unit that is based in the middle of a field in Kent, so we have lots of kind of challenges in terms of where our young people who are presenting with acute mental illness present to. I think what Steve highlighted earlier in terms of the essential component of having a collaborative approach to this and being rolled out will be particularly important. And I think as well, in terms of the document, it does feel quite adult focused, where obviously we are working with an adolescent cohort, which naturally brings about more complexities and challenges in terms of managing safety. But I also think, linking to Steve's point about the individual niche components of services and risk factors. So, hypothetically, we're an inpatient unit. We've had a 14-year-old who's absconded, who's under the Mental Health Act from our unit. That's a risk factor in itself, but we've also got a train track a mile down the road. We've got copious amounts of fields and various other risk factors that contribute to why we might need assistance in that moment. So I think it is really crucial that on an individual basis we're able to make those connections and understand very clearly actually when help and additional support would be warranted, and what instances actually might be more locally managed. And I think, as I said, I know Ellie is quite keen on this point as well, about the fact that from a child and young person perspective, actually where the components fit in terms of safeguarding, in terms of key responsibilities, I think it's a really important point. I don't know if Ellie, you want to add anything?
Yeah, I mean, I think we've got similar thoughts on it, and I know that the document does touch on children and where they're involved and how that would be kind of more bespoke, I guess, in terms of looking at the best interest of the child. But yeah, definitely, like Sarah was saying, I think it definitely needs to be collaborative with other services. I mean, the difficulty that we have with children is if police, if they are out on their own and police attending and we can't get hold of the same kind of issues as what you were saying around kind of next of kins and things like that, is the welfare of the child and not responding to that at the time. I think possibly it's a little bit different in regards to kind of the 136 challenges, because our health-based place of safety is staffed 24 hours, and we take over that care when police come with the young people. So it is slightly different. I know, looking at the article, there was talk about police remaining for hours and hours with the young person, but how our kind of health-based place of safety is set up would be slightly different. So I guess I'm not saying we don't have any challenges with police remaining, but we don't tend to have those kind of significant challenges. I guess the flip side of that is if our health-based place of safety is full because we only have one bed, is that the police would then need to escort the young person to A&E and remain with them. And I know that there was talk in the article around and discussions around handing over to acute trust, but again, whether that would be appropriate with young people. So there's kind of lots of things, I guess, that are slightly different with young people than it would be in kind of the adult world in regards to mainly kind of safeguarding young person and whose responsibility that is and where that responsibility can be handed over to.
Thank you both. If I could just ask a couple of quick questions. In your experience, particularly working with children and young people, do you feel that mental health gets the attention it deserves versus physical health, and does the balance feel right?
Oh, I think it's really tricky, that question, because we can have those presenting with a mental health difficulty who also have significant physical health needs as a direct result of their mental health challenge, but also we have those presenting with, who have taken really significant risk-taking behaviours that have led to a physical health difficulty as well. I think there's still stigma around those with mental health challenges. We hear it quite a lot within our crisis care pathway about young people perceived to be time wasting or resource wasting in terms of when potentially repetitive risk-taking behaviours are taken, and actually there seems to be a kind of disconnect between the reason why those risk-taking behaviours are happening versus kind of what we see. So as in, what's driving that behaviour. And I think that really does link to, again, the article mentioned it about, healthcare professionals, mental health trained as well, being those who have the more experience in that area. But I think that doesn't disregard the fact that we still need to be thinking as a system, sharing about the understanding of mental health versus physical health, but also the connection between the two, but also really working collectively as a wide system, multiple organisation level, in terms of challenging that stigma that I think those with mental health difficulties do still significantly suffer from.
Yeah. Ellie, did you want to add anything, or Steve? Ellie, do you want to go first?
I mean, I think Sarah's touched on most of it. But yeah, I think definitely that we do have that stigma across the system. I'm not just kind of putting it on one service, and also similar to kind of the physical. I know we was talking about physical and mental health, but also the social side, and how some young people are presenting, although they are presenting or with risky behaviours. Some of that is due to kind of social background. So understanding kind of across the board, especially from social care, in regards to how that can have a knock-on effect to mental health as well.
Thank you, Ellie. Steve?
Yeah, just in terms of that question, part of our process in Rochdale this year has been about changing the way that we develop our planning in relation to children and young people. So we're developing a children and young people's plan, which is purely led by the voices of young people. And what I've been surprised about is to the degree that young people understand and appreciate and grasp issues with mental health that I'd not connected with before, and it's a real issue for young people right across the piece. In Greater Manchester, we the Combined Authority have developed the Be Well survey, which it's happened over the last couple of years. 60,000 young people have participated over 185 schools, and it's developing and become more nuanced, and it's examining issues of their emotional well-being, right across the piece. Particularly interesting, post-pandemic. And what's fascinating about that is that the issues that we and the responses are down to a ward level, down to a school level as well. So issues for young people, I don't know, young people who are trans, LGBT, with particular spikes across the piece. Issues of loneliness with young people that we've not picked up. Issues around social media, which seem obvious in relation to bullying, but young people being increasingly lonely in particular areas, or not accessing activities, and that has enabled lots of our services to be able to respond in a much more nuanced and informed way about mental health, in order to prevent escalation, which has been a really lovely thing, and that's been rolled out across Greater Manchester, which is brilliant, but is now also being rolled out in the southeast. So there'll be some comparisons as well. But that kind of approach, that genuine understanding of lived experience, in addition to understanding the data in terms of demand from the different agencies, it's really crucial, and it's irreplaceable in terms of that being able to effectively utilize scarce public resource in this kind of environment.
Thanks, Steve. I'm going to bring Isak in now. Just a reminder to participants to pop your questions into the Q&A. I've got a couple here, but Isak, do you want to come in?
Yeah, thank you, Andrew. Yeah, just a question to everyone, really. It kind of touched on what Sarah mentioned earlier around looking at the reasons behind why a person may exhibit certain behaviors. So that example that I gave in my article, although the person wasn't deemed sectionable after dealing with them in that incident, there were clear signs they were displaying. And I think what you mentioned, Sarah, around looking at the reasons why someone's behaving the way they are, rather than just looking at whether they're capable or not, or mentally capable or unwell, it would actually solve a lot of the problems. So things like isolation. So a lot of these people, when they hit the age of 18, they haven't got that family network around them, or somewhere without a concierge, locked up in a room essentially, and they haven't got any sort of network to kind of rely upon. So oftentimes their sort of first point of call is 999, or to have that sort of human connection. And my question is, I guess, do you find the procedure very prescriptive? So, okay, you've come into contact with someone, actually they're showing signs of mental instability, you go on to try and take them to a health-based place of safety, they're deemed capable and fit, but that's the end of the story. But then 3 days later, the same thing happens again. So how do we kind of look at some of those things which aren't really obvious, i.e. the isolation angle, or the fact that it's not just the mental health angle? Yeah, that might be a part of it, but there's more to it, underlying it. How do we kind of reach into those? And I think some of the work around early help and young people may be able to inform some of this, because not that there's more of an emphasis on young people, but there seems to be more of a safety net, if that makes sense.
Thank you, Isak. Sarah.
I think that's a really good point, Isak, because if it's, obviously I'm coming from a perspective of young people, but if we think about young people who present multiple times in our health-based place of safety, and we mean a few days apart, that they're repeatedly having to be admitted, largely a big contributing factor for that is something called developmental trauma. Now, a young person having developmental trauma, before we're able to do any kind of psychological support, treatment, intervention, that person has to have a safe base in order for those then ongoing work to be effective. And what we find is a lot of young people who do have multiple admissions to the health-based place of safety are coming from the looked after child cohort, or are known to social care, who don't have that safe base, that stability, in order for then the other work to kind of build upon. And then what you see in those particular young people is a real escalation in their behaviours and the type of risk that they then take, which then leads to multiple input from multiple services. And then the perceived risk of that young person kind of just feels extremely large. But I think, a lot of the time, we've had some really complex cases ourselves recently, and I think actually a core factor is about the understanding of the drivers for why this young person is doing what they're doing, is a really core component that I think sometimes, because of lots of reasons, but can sometimes be missed. But I think that is something, I think in terms of learning and moving forward as a system and as a network, is about how we can challenge having those conversations in a slightly different way, to then kind of get a better result for the young person.
Thank you, Sarah. Yeah, that's really good. Steve, do you want to? You got your hand up just now.
Yeah, I was just gonna come in there. I completely agree. I mean, one of the things that that we're doing in Rochdale is around trying to become a more trauma-informed system. I mean, the language of that is not new, and it can be quite it's quite on trend at the minute. But what we're actually talking about is having a more systemic and purposeful approach to understanding children and young people's needs and families' needs. One of our colleges, Hopwood Hall, is 5 years into becoming a trauma-informed college. And that's been transformational, picking up on what Sarah was saying, for our young people who are care experienced or who have experienced particular significant disadvantages or complex issues within their lives. And it's transformative in the sense of the way that the college approaches the individual, understanding their needs, understanding the community, and actually enables young people to thrive within an educational context where they previously have been unable to, for all sorts of difficult and valid reasons. So we're using that as a catalyst for growth across all of our areas, all of our services across the system. We have there's a real commitment from the police, Greater Manchester Police in Rochdale, around the development of child-centred policing, and which is really interesting. And they have put the money where their mouth is, really. And we have we've developed a transformation team to develop this work and other work across the system, and the police are piloting a full-time transformation officer within that team to look at how we can further develop this work. Some wonderful examples in Lancashire. I know South Wales do some really interesting stuff as well in relation to policing. It's about, going back to my original point, without at the risk of repeating myself, it's got to be whole system. It's got to be all of us, and it's not easy. And we've got to continue to try to collaborate, work together, and understand the demand and the need of communities from a data perspective, but also that lived experience, because then you can utilize public money in a much more effective way than ever before.
Thanks, Steve. While I have you, Steve, just there's a question here about the mayoral combined authority in Greater Manchester. It's obviously one of the more developed ones. In your initial comments, you mentioned the combined authority, and I'm just wondering what role that plays, or whether that makes life easier for you at an individual council level, having some stuff done across GM, because obviously the police is across GM, and does that help?
It does help, yeah, it definitely does help. So we have 10 authorities. We collaborate on all sorts of different things. The combined authority works well. Obviously, we have our mayor, Andy Burnham, who's very proactive. It's not easy. It's not an easy area, Greater Manchester. There's it's got a bit of everything. But that collaboration certainly does work, and we take a lot from our conversations at a GM level down to place level. So at a Rochdale level, for example, in my case, I chair the Greater Manchester Education Leads Group, and also the Greater Manchester Enriching Lives Group. So things that happen outside of the classroom, and there's always a lot of learning and collaboration. It's always a challenge, though, in terms of the time that you give at a GM level to the challenge of actually delivering at place level. So I think wherever possible, those things have got to you've got to be able to try to connect and schedule into real issue across the piece. But yeah, I think it can only be an advantage. I mean, Greater Manchester Police do a great job. They've had some challenges, like many areas over recent years. And And I think the thing for us is enabling things to work at a place level, and then thinking about neighbourhoods and hyperlocal, because strategy is wonderful and it can sound lovely, but unless it's actually making a difference, it's just noise. And so it's about being able to weave the micro and the macro in a kind of constant loop.
Yeah, thank you, Steve. And a question for Ellie and Sarah, just a general question, really, just thinking about your own practical experiences. What are the biggest challenges that you think, in a very practical sense, prevent really good collaboration?
I think there's multiple factors really in terms of all services are experiencing high demand, and when that's coupled with significant complexity of those presenting with mental illnesses, but also then you've got the complex mental health difficulty coinciding with potentially social care challenges or relationship breakdowns, and all of those things then, particularly those young people who present into the health-based place of safety, where actually we might do a mental health act assessment and deem that they then don't have a mental illness that warrants detention in hospital, but actually they end up remaining in the health-based place of safety for a significant period of time because of those complex factors that create a bit of a block in terms of finding a more suitable alternative provision for that young person. So I think all of those things can then create kind of blocks along the way in terms of that kind of seamless journey for a young person, which I know Ellie and I in our service have been doing lots of work locally in terms of how we can improve those connections, particularly with our police and social care colleagues, but also our acute services as well, with various things that we've got piloting to try and improve that patient experience. But I think it is a case of trial and error at the moment in seeing what works and what doesn't work to try and then kind of work through those challenges and barriers.
Sorry, Ellie, did you want to add anything?
Yeah, I mean, I would just add, I guess, an understanding across services and the kind of perception of, I suppose mainly for us is kind of what an inpatient admission can do. I guess from other services, it feels like sometimes there's this perception that that's where they'll be safest, and that's where, if we put them there, we detain them, that's going to keep them safe, and that's going to kind of solve some of the issues. And actually we know that for a lot of young people it can be quite detrimental, hospital admission, and can actually increase those risks, and that doesn't support kind of then discharge when we're looking at getting the young person back out in the community. So I think sometimes that can be a barrier to kind of being the solution, I guess, the problem, especially with our health-based place of safety in regards to kind of if they remain there. I guess the clue's in the name, it doesn't help. It feels like, that's going to be the safest place for them, when actually it's it can be detrimental at times. And as I say, it doesn't necessarily mean that risks will decrease. So obviously from a mental health perspective, sorry, Sarah, did you want to say something?
I was just going to say, while you're saying about that, that's really difficult, isn't it? When you've got a young person who is presenting so risky, with then an inpatient unit saying this isn't the best place for them, that actually then the kind of collaboration between those two positions can become really difficult in terms of how we then move forward with what is best for that young person if you've got kind of two opposing positions going on at the same time. Sorry to interrupt you then.
Yeah, no, that's definitely, that was going to be pretty much what I was thinking anyway. Yeah, so that can be a real difficulty. Obviously from a mental health perspective, in terms of our service and what we can offer in the community, that's kind of ongoing and always developing. So that's something that we can offer. But I think there is this real kind of thought process that if they are in a place and in a unit and locked, essentially they are going to be safer, which makes things really hard sometimes.
Thank you, Ellie. Thank you, Sarah. As I'll come to you, and then I've got a couple of good questions in the Q&A.
Well, thanks, Andrew. Yeah, just a quick question around talking about some of the problems when it comes to having an idea strategically and having this idea that's on paper going to work really well, and then how do we get this to actually work in practice. So from other examples where it's kind of worked well, so like where you have multi-agency safeguarding hubs for children, where teams are co-located, so you've got police officers, local authority and the NHS in the same room. Do you think there's any sort of benefit in having something similar when it comes to mental health? Because I don't think there is, from my experience in the Met. I don't know about other forces where there is that sort of same level of day-to-day collaboration. Would that be something that could potentially ensure this actually works in practice? Because it seems to work from a child safeguarding perspective, but I guess this may have different challenges which the co-location might not be suitable for.
I think it is important that it's considered from you've got that kind of broader perspective, but also a more localized perspective is really important, because you're going to have services that have different niches that contribute to how this would or wouldn't be successful. So I don't think it's the not for the want of trying, or not for the want of it, being appropriate, right care, right person, that's really important. But I think it's practically understanding from kind of each perspective actually what some of the blocks and challenges might be that then collaboratively we work through. Because just thinking about our hospital, we don't have on-site security. We're in the middle of a field, literally in the middle of a field. So even those two factors in itself, next to the railway station, are three very core points that actually having that collaborative discussion about actually, in this scenario, this would mean you need to do this. In that scenario, this would mean you would manage that, I think would be key.
Thank you. Just a couple of quick questions. I've got a question here from Adam Chiesa. I hope I'm pronouncing your name correctly there, Adam. Apologies if not. What approaches have been used, if any, in supporting the mental health in communities at a neighbourhood level where mental health may be more stigmatized or taboo, such as the example given in the question is some of the traveller communities? Does anybody want to?
Yes, I can respond. So in Rochdale, we do quite a lot of work with gypsy traveller communities, and also like many areas have had an influx of refugees. So we've done an awful lot of work over this summer, for example, enabling those children and those families to be more settled, and also do some extra work with them, with those children, enabling them to have the best possible chance of thriving when they start school and when they attend school. And so there's been some fantastic work with our teams. But like anything, it's about understanding the lived experience of those communities and not just assuming. In relation to that, Rochdale is also a really ethnically diverse place. So we do an awful lot of work with communities, particularly in relation to family learning. And whilst that's not a mental health intervention as such, it's about the relationship and the whole system and the engagement, which then enables access to a myriad of other services where appropriate, because there's that connection and that interaction. So it's not, as long as people are accessing some of their primary needs and those have been met, then there is an opportunity then for that wraparound provision to actually take place where the support is needed. If we're working in isolation, those things are more difficult or not possible.
Thanks, Steve. Anybody want to add anything, or shall we move on?
Just to say, from our perspective, we're always looking at ways that we can increase our patient participation and lived experience into our crisis care pathway and inpatient services, and thinking about how particular different diverse groups are able to access mental health support and what some of the challenges for that might be. So, you know, we do have a patient experience / involvement team where we look at particular themes to see how we can improve that for our cohort of young people.
Thank you. Thank you very much, Sarah. So I've got really good questions from, it's anonymous, but it's a really good one, and it's one that I had jotted down here. It's quite long, so I'm going to read it all out and we can unpack it. So the transition from child social care and support to adult services is far too wide, where children and young people are falling through the gap. So I had this question jotted down, Isak and I talked about this beforehand, about that transition. There's also the fact that ethnic minorities are disproportionately diagnosed with mental health conditions, leading to being sectioned, medication. How can this be challenged? There's another part to the question, but I'm going to pause there. So there are two elements to that so far. One is that transition from children to adults and not falling through the gap, and then also about ethnic minorities being disproportionately diagnosed. That's from the question. Sarah, I'll come to you first.
Yeah, so we within our service, again, that's identified as a particular risk point for young people. So we've actually got, because the children's services are operated by one trust in Kent and the adult services are operated by another trust, so that can obviously cause some challenges as well in terms of transition. But in our service, we've got a post that works across both trusts, which is a transition lead clinician, who then looks after all of those young people who are 17 and a half and making that transition to adult services, to ensure that those gaps are addressed and what needs to be put in place has been put in place before their 18th birthday.
Thank you, Sarah. Steve or Ellie, do you want to come in?
Yeah, I think for us, I suppose it was a kind of part of my response was with the previous question, where where Rochdale is quite an ethnically diverse area, so we have a number of different responses. Really, I think wherever possible, that lived experience of those communities and that understanding of those communities needs to be not just about the service. So we work with our local mosques, our local imams. You know, we work with local voluntary groups in terms of understanding. I mentioned about family learning, which is predominantly accessed by Southeast Asian families, and it's we have a number of different routes into those communities, and also recognizing that the importance of access to those community leaders is really, really important, and not making any assumptions about how and when to engage, and keeping that constant dialogue alive and well is really, really crucial. I think the point about the transition, I think it's really key. I'm thinking particularly in relation to special educational needs. We have discovered in Rochdale that we've been looking at that transition maybe too late. You know, maybe thinking at kind of 17, 18, etc. But actually, we should be thinking about these things at maybe 14, 15, and getting that life plan for some of those young people whose needs won't necessarily change in a dramatic way during that period, and thinking about actually, do we need one system, one service, one provision in relation to that transition? But I think sometimes gaps can appear, and it's not a healthy thing. So I think the more that we can understand that pathway and that journey on a much earlier setting, the better.
Thank you, Steve. Just coming back to the second part of this question, really is more of a comment, but you know, how can communities trust and engage with mental health if there are obstacles are already in place? And I think what the point being made here is, you know, one of the questions again is what happened to early intervention, and when services are being cut, that encourages crisis intervention, where situations have already gone too far and where the police become involved, which adds another layer of mistrust and anxiety. So not so much a question, just a comment really, I guess, from that person on the situation. But it'd be great just to hear from you all what you feel is positive in terms of what's happening in terms of early intervention and things like that. Steve.
Yeah, I would say, I mean, I suppose the comment was about cuts, wasn't it? I mean, nobody would recommend that in relation to services, but it has been a reality for a long time in terms of restrictions of public resource. What I would say is it's even more important, therefore, to collaborate. It's even more important to understand need in a much more nuanced and purposeful way. It's even more important to have an outcome-focused alliance rather than service-centric solutions. And it's even more important to be able to utilise scarce public resource in the most effective way. And you do that by engaging with people and understanding the data and prioritising relationships and relational approaches at all levels. It's really challenging. I mean, part of the temptation when resources are tight is that people kind of retract and pull, batten down the hatches, if you like. And that's exactly the reverse of what you should be doing. You should be having the difficult conversations. You should be getting around the table. You should be challenging appropriately each other in relation to the resources that we've got, because we don't serve different communities, regardless of where we sit in the system. We don't serve different communities. We don't serve different people. We're all public servants, and we need to collaborate. It's not a choice.
Yeah.
We need to do it effectively. Resources are tight, and sadly, in many areas, demand is rising. We've got a cost of living challenges, high levels of poverty. It's tough for lots of people in our communities, and so the moral and logical choice is to collaborate.
Yeah, thank you, Steve. Just the final question, really, from me. So I want to let people get away a couple of minutes before. Just maybe for Sarah and Ellie, is the NHS reorganisation, which is ongoing at the minute with the emergence of integrated care systems and that kind of closer local collaboration, is that creating opportunities for local areas, let's take Kent and Medway as an example, to tailor what their offer to the public is more specifically to your needs, or to the needs of your population?
Yeah, absolutely. I think the developments of the ICS and then the ICB is really key, because what happens is, so if we think for inpatient services, we're in a partnership with our provider collaborative colleagues as well. So, and that, the basis of the ICS is that it is a more collaborative joint up approach. And I think that is really important, that, providers and commissioners are able to kind of see things from a particular viewpoint that brings about those connections in a more meaningful way, with the people being at the center of that is our service users. So for me, certainly having experience pre and post, I think it's really beneficial.
Yeah. Thank you. Ellie, did you have any final comments or anything you wanted to say before I draw things to a close?
I think Sarah did sum it up very nicely. But yeah, I guess I do feel like we are quicker to kind of work with our colleagues in regards to kind of like multi-agency meetings and getting multi-agency risk plans for our young people in place a lot quicker when we do have young people who present with particularly risky behaviours, to try and encourage that community care and kind of prevent going down admission, sectioning, all of that thing, all of that route. And also that would kind of carry on, as we were saying, to transition to adults, because we do see a lot of kind of 16, 17-year-olds that we need to make sure that they're not going to then get stuck in an adult system as well with mental health, so improve their outcomes.
Thank you, Ellie. Steve, anything you want to say that you haven't had a chance to so far?
No, I don't think so. I just to go back to the point about the initiative that the Met are running. I think it's potentially a brilliant thing, but it just needs to connect, and without connection to a local authority level with all of those services, it won't work as well as it perhaps will be intended.
Yeah. Thank you, Steve. I would also appreciate you acknowledging that about what the Met's doing, because I think the way, if we were to just take how things were initially reported, which is to immediately look for the bad, the kind of headline in it, that is it's really interesting that you've taken the time to sort of dig beneath that a bit and explain what they are actually doing. Esak, any final thoughts before we wrap up?
No, but just want to say thank you for engaging in the discussion, and it was really interesting hearing the different views around the importance of early help and that transitioning period, which I think is key. So yeah, thank you.
Absolutely. So thank you very much, everyone. Thank you, Sarah. Thank you, Ellie. Thank you, Steve. Thank you, Esa. And thank you, everybody, for listening. We will get the recording of this and send it to everybody. Obviously, we haven't used any slides today, which I think is great. It just keeps it a really good conversation. So the recording will be sent around. And thank you, everybody, for taking the time to join us. And I think we've done quite well holding on to people right up until the end. So that's always a good sign. So thank you very much, everyone, and have a good rest of your day.